Hope I'm audible. So let's begin. So we finished off with benign disorders. We already saw that whenever there is going to be a glandular pathology, we were suspecting the problem of ranula, and whenever there was a ductal pathology, it was a retention cyst or a mucocele. So we have very well seen it in the yesterday's lecture. Now we are going to start off with what is called as salivary gland tumors. So salivary gland tumors can broadly be divided into major gland tumors and minor salivary gland tumors. So always remember that in house, the major person, so the elder brother or the elder sibling is always considered to be quiet, but the small kid is going to be notorious. Same is the problem here. So the major salivary glands here are going to have 80% of the benign tumors, and the malignant tumors which are going to come are going to be from the minor salivary glands. So almost 60% of them are going to be malignant, and they are going to be formed specifically at the hard palate and the lip and at the lips. So most common tumor overall in any salivary gland is going to be pleomorphic adenoma. So pleomorphic adenoma, as the name suggests, it is going to have multiple morphotic cells. So it is arising from multiple morphic cells, hence it is a pleomorphic adenoma. Adenoma is a name called as benign. It is the most common benign tumor, and the most common malignant tumor is going to be mucoepidermoid carcinoma, and we are going to see that it is going to have a good prognosis. So there are almost 20 to 25 different types of salivary gland tumors given. But if we are going to start off with rectifying everything, so I think the surgery will only remain regarding the salivary glands. So it is not important for you to know every bit of it, but basic management principles should be remembered by you irrespective to the type of the tumor. Warthin's tumor most likely in males, and again remember that Warthin's is also the second most malignant tumor. Pleomorphic adenoma is more common in females. So males में कौन सा tumor दिखेगा? Warthin's tumor. क्यों? क्योंकि it is associated with mostly smoking. Nowadays, even females are going to smoke, but still it is still found more in males. Risk factors for salivary tumors. Always remember that a radiation is going to be the risk factor. So what is another malignancy which is going to happen after radiation? So another important malignancy is going to be a thyroid malignancy. And third important malignancy which is going to happen after radiation is going to be oral cancer. We have already seen all those type of the tumors. And what is SUMP? So it is called as salivary gland undetermined malignant potential. So you are going to send a tumor pathology biopsy specimen or an gland excision specimen, and after sending, they are going to label it as SUMP. So SUMP is something which is called as salivary gland undetermined malignant potential. So here what you are going to do, you should not give for any systemic therapy like chemo or radiation. You are just going to go for a close follow-up. So it is very much important. So benign salivary gland tumors. So first tumor is going to be your pleomorphic adenoma. These are some factual things which you should be knowing. Again, remember, as the name suggests, it is the most common tumor. It is originating from multiple morphotic cells. So 30 to 60 years can arise at any age, any salivary gland, but parotid being the most common. Parotid सबसे बड़ा gland है, तो obviously maximum tumor उधर ही दिखेंगे. Deep lobe of the parotid gland. Sometimes it can also be present in the deep lobe of the gland. We have already seen that this is the parapharyngeal space. We saw that the parapharyngeal space is divided into pre-styloid and post-styloid component. So here what is important, so here you know that if the deep lobe is going to be involved, it is going to push the pharyngeal wall medially, and that is the time when you are actually going to see something called as tonsil swelling. So sometimes you might miss a tonsil swelling for a pleomorphic adenoma or some mass growing out in the parapharyngeal region. So always remember to get a CT scan done in cases of non-resolving tonsil. So I hope it is very much clear. Now we are going to talk about clinical. So it is a slow growing painless tumor, and it might be associated with facial palsy, but remember it is rare. So any facial palsy, so if you are going to see a facial palsy, consider is malignancy. So whenever it is going to be ingrowing into the nerve, it is going to be malignancy unless otherwise proved. Immunohistochemistry, it is going to be CK strong positive. Some exam factual question. So an exam question might come to you that a patient had a salivary gland tumor, biopsy was done, it is a CK positive tumor. What is the diagnosis? So it is a pleomorphic gland adenoma. So always remember that if it is arising from the superficial part of the gland, you are going to do a superficial parotidectomy. Always remember to take off some cuff of the tissue. Why? Because these tumors are predominantly having some pseudopods. So those pseudopods can remain and the tumor might recur. So there are high chances of recurrence. And why to remove this tumor? Because there is a tumor which is called as Carcinoma ex pleomorphic adenoma. So what is this? So whenever the pleomorphic adenoma is kept for a long period of time, it can actually form a new malignancy in the underlying lesion. So it is called as Carcinoma ex pleomorphic adenoma. So a carcinoma which is going to develop in a setting of a pleomorphic adenoma which is there for a long period of time, it is considered to be a carcinoma. So any pleomorphic adenoma should undergo excision. Never enucleate the lesion. Enucleation means opening the capsule and then scraping of the tumor. Never, because enucleation causes capsular breach, and microscopic tumor cells can cause a lot of recurrence, and up to 45% recurrence is common. So always excise with a cuff of normal tissue. So always important for you to know that always remove it with some cuff of tissue. Excellent. then malignancy can be formed. Carcinoma ex pleomorphic adenoma, if it is kept, 10 to 15% of the patients might have this malignancy, and it is going to be very much rapidly growing. And always remember, any tumor in the parotid gland, may it be benign or malignant, it is going to cause pain. So why pain is going to be there? Because the salivary gland is it is going to be encased in the deep cervical fascia. So any type of stretching in the deep cervical fascia is going to cause pain. So all the salivary lesions are going to be painful. So ऐसे नहीं है कि बस abscess है तो painful है, तो tumor can also be painful because it is going to stretch the capsule of deep cervical fascia. Second most important tumor is the Warthin's tumor, 50 to 70 years. Again, it is male predominant we saw, and it is strongly associated with smoking. अभी धीरे धीरे जैसे लड़कियां स्मोक करने लगी है, ये लड़कियों में भी दिखेगा. So might be the next edition might say that it is equivalent in males and females. So the time is not far. Location, it is exclusively in the parotid gland and predominantly at the lower lobe. Bilateral association होता है क्योंकि smoking है तो it is going to be smoking. So field cancerization we saw in the oral cavity. Field cancerization नाम से हमने कुछ पढ़ा था, तो इसके वजह से it can happen in any part. It is a soft, fluctuant and painless swelling, and again the facial palsy is rare. So facial palsy matlab almost it is going to point towards malignancy. So any patient with facial palsy with parotid tumor, it is considered to be a malignancy unless otherwise proved. Histology, it is going to be lined by ductal epithelium with some lymphoid tumors. So always remember that isme there is going to be some component of the lymphoid tumors. It is going to have some component of lymphoid tumors, and if it is going to be kept as it is, it might progress into lymphoma. So very much important for you to know कि अगर pleomorphic adenoma वैसे ही रखा तो it is going to form what is called as carcinoma, pleomorphic X carcinoma. But if the Warthin's tumor is going to be kept as it is for much days, उसमें lymphoid follicles grow करेंगे and there are chances of development of local lymphoma. Malignant salivary gland tumors. So always remember, इसमें भी management क्या है? Superficial parotidectomy, and it has a low recurrence rate because pseudopodia नहीं रहते. So what are the malignancies? So this is a mucoepidermoid malignancy, typically seen in young age and adults. So nature is very much caring. So बच्चों में जो चीजें वो देता है, तो those are curable and those are less malignant. So always remember that despite being a malignancy, it has a low grade, it is a low grade type of malignancy, and it has excellent prognosis. And always remember that अगर उसमें patient को थोड़ा सा extranodal extension या फिर lymph nodes है, तो you can go for nodal disease and adjuvant radiation. So any salivary gland tumor, the management is going to be excision, excision and excision, followed by that अगर lymph nodes involved है तो lymph nodes भी निकालो, and उसके बाद में अगर high risk features है, तो कोई भी tumor में high risk features कोई पूछेगा तो नींद से उठ के पता होना चाहिए lymphovascular invasion, extranodal extension, perineural invasion, atypia of the cells, high grade malignancy. So any type of high risk features are going to be signifying for a radiation therapy in the head and neck cancers. Very much important. So it is seen in young children. Parotid is the most common. It is a low grade cystic neoplasm and intracellular mucin on past staining. So it has mucin positive. So when we are going to discuss the colonic cancer, उधर भी हम mucin का बात करेंगे, but mucin in colon cancer is a bad prognostic factor. So what I said, yes. So if it is going to be a mucin in the colonic cancer, it is a bad prognostic factor, but mucin in the parotid lesion is going to be considered as a good prognostic factor. So more amount of cystic component, it is low grade, and more solid, it is going to be high grade. So always remember that low grade has excellent prognosis, high grade में हमें adjuvant radiation therapy भी देना है, but it is one of the carcinoma with very good prognosis. And now comes the malignancy which has the worst prognosis, which is adenoid cystic carcinoma. So चार ही चीजें याद रखो, उसके बाहर अगर तुम्हें कुछ याद रखना है तो that is your brain. 4 important malignancies: pleomorphic adenoma, Warthin's tumor, then mucoepidermoid malignancy, and adenoid cystic cancer. So it has the worst prognosis, can affect any age, it is associated with facial palsy, and it has a delayed tendency to cause metastasis. So while dissection of the tumor, there might be, the body might be clear, there might be no evidence of metastasis, but बाद में से years to 10 years बाद अब तुम्हें पता चलेगा कि उसको full blown pulmonary metastasis हो गए हैं. It has typically cribriform or Swiss cheese appearance. सर ये तुमने क्यों लिखा है? The reason for me to write is these pointers are for MCQs. So cribriform Swiss cheese pattern is seen in histopathological diagnosis. तो इसका मतलब मुझे क्लिक हो गया कि if cribriform pattern है तो worst prognosis कौन सा ट्यूमर है? It is adenoid cystic carcinoma. Radical single setting excision with radiation is the only treatment. Chemotherapy कोई भी salivary gland के लिए उतना effective नहीं होता है. So prolonged surveillance for late metastasis is very much important in these malignancies. So एक surgery अगर तुमने किया तो ये patient तुम्हारे पास हर 2 साल में आने वाला है follow up के लिए, and every time is going to pay you. So always remember that this tumor is going to have very bad prognosis. Now we talked about carcinoma ex pleomorphic adenoma. In the existing background of pleomorphic adenoma, sudden rapid growth in the stable swelling. So it has that invasive component of cancer, and always remember that if it is non-invasive or minimally invasive, it has good prognosis, but if it has a frank invasive pattern, it has a bad prognosis. You should go for radical excision with, along with that you should go for you should go for adjuvant radiation therapy. Other type of cancers, acinic cell cancers, usually parotid, low grade, young adults, it is पास पॉजिटिव. सो जो इंपॉर्टेंट चीजें हैं वो मैंने नोट्स में इंक्लूड किया है. सो पास पॉजिटिव ट्यूमर, इट इज गोइंग टू बी एसिनिक सेल कार्सिनोमा. Swiss cheese pattern is adenoid cystic carcinoma. And the third important thing is when there is going to be a cystic component, so adenoid cystic carcinoma with good prognosis. So these are the things you should hammer in mind. तो मेरा नाम तुम्हें याद आना चाहिए, तो सारे पेपर में आप लिख पाओगे. Wide local excision with adjuvant radiation. No role of chemotherapy in salivary gland tumors. Salivary duct cancer, तो अभी इतने बार हम लोगों ने gland के बारे में बात किया, तो अगर उसके duct का कैंसर हो गया तो it is very much aggressive and it resembles the breast ductal carcinoma. So duct carcinoma, breast के जैसे duct carcinoma है. सर ब्रेस्ट को क्यों इधर इन्वॉल्व किया? बिकॉज इट इज गोइंग टू बी हार्मोन सेंसिटिव. So HER2 expression उसमें हो सकता है and even it might be androgen positive. So here you can give hormonal therapy. So अगर salivary duct का tumor है तो one take home point is yes, it might be a hormone sensitive cancer. So you can give what is called as an androgen deprivation therapy. और अगर HER2 positive है तो you can give trastuzumab. So मुझे ये सब चीजें पता चल गई. Always remember. So अब हम एक flowchart बनाएंगे जिसमें we are going to see that how are you going to manage the patient of any parotid or any type of salivary gland lesion. So अगर patient आया salivary gland lesion के साथ, so first you are going to do a local USG. So USG करने के बाद में मुझे पता चलेगा कि is it actually the salivary gland or is it the lymph node, and उसके साथ I am going to do an FNAC. FNAC करने के बाद में मुझे पता चलेगा कि it is going to be a benign or malignant. Is it true? So no, it is not true. Here FNAC is only going to differentiate. FNAC is only going to differentiate, if you can see here, FNAC is only going to differentiate between inflammatory or neoplastic lesion. It cannot tell whether it is benign or malignant. तो कैसे पता चलेगा benign और malignant? तो आगे आएगा. So here you are going to do FNAC to rule out inflammation. So inflammation ही FNAC इधर रूल आउट करेगा. FNAC will not tell the type of the tumor और ये. उसके बाद में हम करेंगे CT plus MRI. सर दोनों चीजें इंपॉर्टेंट है क्या? Yes, if you are planning the patient for conservative management, CT and MRI are justified. अगर तुम्हें पता है कि ये malignancy है, old age patient है, it is more pointing towards malignancy. If there are high risk features like facial nerve palsy, तो it is malignancy. Don't waste your money in MRI. But CT scan is important. CT is going to differentiate it from an abscess. CT is going to differentiate it from an abscess and MRI के बेसिस पे तुम्हें पता चलेगा whether it is benign or malignant. So ये दो investigations are very much important. And उसके बाद अगर फिर भी तुम्हें डाउट है कि पेशेंट को कंजर्व करना है या रेडिकल सर्जरी करना है, तो you can go for a biopsy. Always you can go for a biopsy. बट बेसिक इन्वेस्टिगेशन क्या है? सलाइवरी ग्लैंड न्यूप्लाज्म अगर मेरे पास आ गया तो सबसे पहले व्हाट आई एम गोइंग टू डू यूएसजी प्लस एफएनएसी. एफएनएसी इज गोइंग टू रूल आउट एन इन्फ्लेमेटरी साइलेडेनाइटिस एपिसोड. सीटी एंड एमआरआई. सीटी इज गोइंग टू डिफरेंशिएट एब्सेस, along with that it can also tell about the stones. CT is going to differentiate it and MRI is going to tell me, the MRI features are going to tell me about the benign or malignant lesion. So if it is going to be a benign, I am going to go for a conservative approach. If it is going to be malignant, I can go up front for surgery. Still you are confused, go for a biopsy. Biopsy will definitely tell you what is the lesion. So it is very much important. That's what is given. FNAC is highly sensitive for inflammatory or neoplastic. CT will differentiate abscess from the tumor or even bone involvement, but it has left soft tissue detail than MRI. MRI is going to tell you about the benign from malignancy and it can also detect the perineural invasion. So MRI is for nerves, it is going to tell you about the perineural invasion, and it might also have an oversensitive attitude. So many times radiologist will tell you about oversensitivity. कि अगर वो benign borderline लग रहा है फिर भी will report it as malignant sometimes. So you have to keep that in mind. And core needle biopsy gives the best architecture. But why you are not doing it for salivary gland tumor? सर ने तो पहले ही biopsy कर दो, पागल हो गया. Why USG, CT, MRI? Because it might cause a small risk of salivary gland fistula. और अगर वो benign निकला और permanent उसको अगर fistula हो गया तो then you are going to be responsible for that added comorbidity to the patient. And also sometimes the facial nerve might be at the risk. So why biopsy is not done routinely in the salivary gland lesions? Because it is a high risk of having facial nerve injury or it might have a post biopsy fistula. Surgical management, so parotidectomy. So parotidectomy is very important, might be asked as a short note in your surgery exam as well. So why it is important? Because parotidectomy is the surgery which can be done at your general surgery level, but there are a lot of important structures we already saw. Facial nerve, then comes the vein which lies deep, and then comes the artery. So any injury to the structures can cause permanent damage to the patient, might not be death, but always added morbidity. So this surgery is very important and having a skillful approach. Incision is going to be a Blair incision. So what is a Blair or modified Blair incision? So I am going to tell you about the different incisions. So these are the incisions. So this is the Blair incision. This is the Blair, or it is called as modified or lazy S incision. It is called as lazy S incision. So when you are going to draw that S in the laziness, that is the lazy S incision. Previously, if you are going for a malignant disease, a radical excision, you can go for what is called as a facelift incision. So जैसे नए cars के facelift आते हैं, वैसे facelift incision can be used. And if you are going to go for a minimal small approach, so you can go for a small approach. So it is also called as a small incision or a V incision. So small incision nearby the parotid gland, wherever the tumor is. If it is benign, you can just go for a small cosmetic incision and you can extract the tumor from that mini incision. So what are the incisions? Blair's incision is most commonly used. Blair's incision is most commonly used. उसके बाद में आता है facelift incision. उसके बाद में आता है small or the minimal invasive incision. Very much important. So incision is a Blair's incision, preauricular curve behind the ear lobule, and it extends vertically down. So initially the Blair incision was only this much. So initially you can see this dotted line. So Blair incision पहले इतना ही था, but now they have extended the line below. Why they have extended the line below? Because इधर से जो nerves and veins रहते हैं, so you know that here there is a branch of facial nerve, cervical branch of facial nerve, and another important thing is you can find out here the retromandibular forming the EJV, and here you can also trace the external carotid artery. So you can go in the neck and trace those important structures. So the incision was extended not for the cosmetic purpose but for facilitating the surgeon. So a Blair incision initially was just at the ear lobule, and now they have extended a limb down, which is called as modified Blair's incision. Very much important for you to know. Facial nerve identification, yesterday हमने उसका बात किया. So first most important thing is the tragal pointer. It is 1 centimeter deep and inferior to the tragal cartilage. Another thing is an upper border of posterior belly of digastric. It lies inferior to the nerve. It is the most consistent and easily used, most commonly used thing is posterior belly of digastric. Tragal pointer अगर पूछोगे तो it is the most specific. But usually हम लोग क्या देखते हैं, posterior belly of digastric देखते हैं. Tympanomastoid suture is also very much important. But in cases of redo surgery, we can go for retrograde tracing of the nerve. So it is very much important. Dissection plane हमने कल ही देखा कि पेटिस फेशियोवेनस प्लेक्सस, all dissection stays within this plane to preserve the facial nerve. Superficial parotidectomy removes the superficial lobe. So always remember, अगर nerve के superficial रहोगे तो it is a superficial parotidectomy. If you are going to go deep, it is going to be a deep parotidectomy. Total parotidectomy removes the entire gland and facial nerve might be preserved if uninvolved or might be sacrificed. Radical parotidectomy में facial nerve जाती है. So radical means you are going to remove the nerve along with the gland and adjacent structures. And parotid bed closure, what is important that here there is an important short note which is going to be a Frey syndrome. Sir, what is Frey syndrome? Frey syndrome is nothing but we know that we already saw that parotid gland is supplied by a glossopharyngeal nerve. So what happens is normally the parotid gland, after you are going to go for excision of the gland, so this is going to be your parotid gland, this is going to be the parotid gland. If you are going to go for excision, the nerve endings are going to stay like this inside the gland blade. So these nerve endings are going to directly stimulate the skin, and the patient is going to start sweating after the removal of the gland, because the gland is not there for stimulation but the nerve endings are present, so they are going to cause stimulation of the local skin and the patient is going to sweat. How to know that the patient is sweating? So we are going to apply starch on that region and apply the iodine. So normally what is going to happen when there is going to be sweating, that is going to be wet, and that wet iodine powder and starch powder will start combining together and it is going to give the starch iodine test positive. The starch iodine test is going to be seen. So this is going to be the starch iodine test. So this is going to be done for confirming the Frey syndrome. पर अगर Frey syndrome नहीं करवाना पेशेंट को तो क्या करना चाहिए? तो you can go for sternocleidomastoid flap. तो sternocleidomastoid को अगर तुम उस जगह पे फिक्स करोगे तो what is going to happen? Whenever the secretions are going to be stimulated, the sternocleidomastoid might be stimulated, and that is the reason it is going to prevent the Frey syndrome. So it prevents the Frey syndrome and also it might prevent the cosmetic deformity. ये जो बल जाने वाला है वो भी पेशेंट को sternocleidomastoid के वैसे ही रहेगा. Very much important. So Frey syndrome, aberrant regeneration of parasympathetic nerves from fibers to the skin, and it causes the gustatory sweating. So whenever the patient starts chewing the food, whenever the patient eats the food, he is going to have sweating over this region. Starch iodine test. So blue-black color change with affected area. We already saw this starch iodine test. 11-12 में हम लोग ये करते थे to rule out the starch present. कैसे प्रिवेंट? पहले तो प्रिवेंट करो. प्रिवेंट कैसे करोगे? स्टर्नोक्leidomastoid फ्लैप लगाओ, नहीं तो नर्व एंडिंग्स को बर्न कर दो. But if at all still it is going to persist, you can inject botulinum toxin. Botulinum toxin क्या करेगा? Botulinum toxin उस nerve को paralyze कर देगा and it is not going to give off any secretions. So you can go for botulinum toxin, or you can go for a later SCM flap beneath the skin, or you can go for a tympanic neurectomy. So you can call an ENT surgeon. He will go inside the ear and he will burn off the tympanic plexus riding over the glossopharyngeal nerve. So वो nerve अगर उसने burn कर दिया तो it is naturally going to stop having the lesser petrosal nerve के all the secretory motor side effects and it is going to cause quick relief. So it is very much important. Post-op salivary fistula. What happens is after you are going to do the superficial parotidectomy, many times the salivary ducts are going to remain. So deep lobe is going to keep on secreting the secretions. So patient will develop a fistula. The patient might have the skin incision from where the salivary gland, so after eating there is going to be expression of the salivary secretions. So persistent salivary leak through the wound, and here the clinically saliva is leaking from the wound. And how to manage it? So you can go for anticholinergics. So anticholinergics deke you can try to control it, but if it is not going to be controlled even after that, then you can go for radiation. So radiation is going to burn off the gland, so radiation can be done, but it is going to carry a risk of increased risk of malignancies, or so you can go for a redo surgery. So what to do in case of parotid fistula? You can go for actually radiation at the end resort, but if the patient is high risk of malignancy, you can go for surgical cautery, redo surgery, and you can go for surgical cautery. That is important. Facial nerve palsy temporary. So many times when you are operating, there might be some edema, and that edema, the traction on the facial nerve might cause subclinical facial nerve palsy. You don't have to do anything. You have to just take care of the eyes, because the eyes will not close properly. So you can give what is called as the lubricant eye drops, or sometimes people can also give steroids to subside the edema. Very much important. But again हमने पढ़ा था कि trauma में there are no role of steroids, so it is only important in case of tumors. So whenever you are going to go for a tumor surgery, steroid is going to reduce the vasogenic edema. Cytotoxic edema, because of trauma, it is not going to be any effective. So when you are going to go for facial nerve palsy treatment, steroid trial can be given to the patient. What is a first bite syndrome? कुछ लोगों में दिखता है. Whenever you are trying to chew the food, whenever you are going to try to chew the food, what happens is during the first movement of the chew, what is going to happen? There is a spasm of the parotid myoepithelium, and patient is going to have a lot of pain in the parotid region. So that is the first bite syndrome. So there might be severe pain at the time of first bite, और उसको भी हम लोग कैसे ट्रीट करेंगे? बोटुलिनम टॉक्सिन. बेलीलव में दिया है, इसलिए I have just included in my notes. Very important. अगर कुछ आया एग्जाम में तो well and good, नहीं आया तो it is going to add to your knowledge. So I hope it is very much important for you. And it is cleared off to you कि हम लोगों ने parotid glands इधर complete कर दिए. So malignant tumors, if you are going to see these tumors, I have included this photo. But देखो, इतने अगर तुम याद रखना चाहते हो तो तुम याद रख सकते हो. मेरा इतना brain sharp नहीं है. I cannot keep on remembering everything of it. What important tumors are there clinically is very much important. We already saw any malignant tumor, radical surgery, high risk features, radiation, then no role of chemotherapy. I hope it is crystal clear. You can write short note in any of the tumors if it is like any of the tumor if it is going to come in your paper or it is going to come in your exam. I hope it is crystal clear. So here we end the chapter of parotid, and now we are going to start off an interesting chapter which is very important for your UG, PG, clinics, everything, that is thyroid. So अगर अब तक कोई doubt है तो please post in the message section. I am just seeing the messages. अरे बाप रे, मेरा ब्रेन चाहिए तुम्हें. ले लो भाई, ब्रेन भी ले लो मेरा. कुछ छोड़ो मत मेरे पास, ले लो. So let's start off with thyroid glands. So thyroid very important for surgery, UG, PG, super speciality, then your clinics, first year, second year, third year, anatomy, सब जगह पे thyroid important है. For a physician also thyroid is very much important. You should know even if you are becoming a physician कहाँ तक patient के graves को medically treat करना है, when to refer the patient for going off for surgery. So very much important topic. We'll only try to cover anatomy, and tomorrow I'll give you the PDF of thyroid gland so that you will have it in your phone as well, so that then we can start off with the actual chapter with the disorders of the thyroid gland and what is the management and surgery of the thyroid gland. Here this point is very much important because I'm going to describe all the nerves in relation to the thyroid gland, where these nerves are going to lie, because it was very difficult for me to get the orientation of the gland. Unless I operated a few cases and assisted a few cases, I couldn't get the orientation of the gland. So it is very difficult for you to imagine actually from where does the nerve go, where is the nerve present. If you are very good at anatomy, it might be very easy for you, but it was difficult for me. So whatever I could do it easily, how I could learn it easily, I have included in the notes, and I hope it is crystal clear to you as well in the same fashion. So let's start off with the thyroid gland. So firstly, embryology. So we all know that thyroid is going to develop in the tongue, and then the thyroid is going to descend off. So thyroid is going to develop in the tongue, and then it is going to descend off. It descends from the foramen cecum at the base of the tongue around the thyloglossal duct, and here the duct is going to be left behind, which is going to penetrate the hyoid bone. So what is the clinical significance? We saw that it might form a thyroglossal cyst. So thyroglossal cyst is going to be remnant of the thyroid tissue in the thyroglossal duct, most commonly midline swelling. And how does it differentiate from the thyroid gland? So thyroid gland does not move on the protrusion of the tongue, but the swelling is going to move on the protrusion of the tongue, so very much important. So thymus, it is going to develop from the third pharyngeal pouch, and it carries the inferior parathyroid. So remember that inferior parathyroid is going to develop from the third pharyngeal arch, and the superior parathyroid is going to develop from the fourth pharyngeal arch. But the third is going to descend down. So along with the thymus is going to take the third gland along with it. Hence, we know that the thymus goes into the mediastinum. Hence, the most commonly the gland which is going to be most common parathyroid gland, which might have ectopic region, or it might go further down in the mediastinum, it is going to be the inferior parathyroid gland and not the superior parathyroid gland. And always remember that inferior parathyroid gland originates from the higher pharyngeal arch, so it is exact opposite. Ultimobranchial body. So what is ultimobranchial body? So thyroid is going to be forming in the two regions. So the midline, the mid part of the thyroid is going to be formed with the help of the isthmus, and the mid part of the thyroid is going to be formed from the thyroglossal duct, which is going to come down from the foramen cecum, and the other lateral aspect of the thyroid lobes are going to be formed from the ultimobranchial body. So from the fourth pharyngeal arches, the ultimobranchial bodies are going to fuse with the thyroid, and it is also going to carry the superior parathyroid glands. So we saw that inferior parathyroids from the third pharyngeal arch along with the thymus, and the superior parathyroid glands are going to form from the ultimobranchial body. Parafollicular C cells are calcitonin secreting cells derived from the ultimobranchial body. So ultimobranchial body is also going to give rise to the what is called as a parafollicular cell. So these are also called as the C cells. So why is the parafollicular cell important? So these cells are going to form malignancy, which is called as medullary carcinoma of thyroid. So medullary carcinoma of the thyroid is going to be formed because of multiplication of the C cells. So basic anatomy agar hum logon ne dekha, to this is how the anatomy is there. You know that this is going to be your the टंग फोरामेन सीकम से यहाँ से वो ग्लैंड का रूट जाने वाला है. इट इज गोइंग टू एनकेज द थायराइड बोन एंड देन इट इज गोइंग टू गो डाउन एंड हियर द थायराइड ग्लैंड इज गोइंग टू सेटल डाउन. बट इन केस द थायराइड ग्लैंड इज गोइंग टू गो even further down, it might go intrathoracic. So along the region, anywhere the thyroid gland might be found ectopic. So what are the regions? Sublingual, intralingual, suprahyoid, infrahyoid, thyroid, cricoid, thyroglossal duct, or intrathoracic. So all these places the thyroid might be found. In the child, whenever you are dealing with pediatrics, not pediatric surgery, in pediatrics the child might have what is called as a congenital hypothyroidism. So that time there are two components. It might be a thyroid agenesis or thyroid dysgenesis. What is dysgenesis? The thyroid gland is present, but it is non-functional because of some congenital problems. So that is called as thyroid dysgenesis. But thyroid agenesis means gland is not there. So whenever you are concluding that the gland is not there, you should see all these regions. And if these regions are free of gland or glandular tissue, then you are going to label the person permanently athyroid. So it is very much important while you are labeling the patient. So this gland is around 25 kg in adults. It is 25 kg in adults. It has cuboidal follicular epithelium. So whenever the gland is secreting phase, you know that the gland has what is called as the follicles, and the follicles are lined by cuboidal follicular epithelium, and each lobe contains 20 to 40 follicles. So एक lobe में 20 to 40 follicles रहेंगे. Normal epithelium is squamous like, so it is a simple cuboidal epithelium. But when the gland becomes hypersecretory, whenever there is going to be hypersecreting gland, in cases of Graves' disease or in case of hyperthyroidism or hyperstimulation because of external TSH or external levothyroxine, it will become columnar. So a gland biopsy, if it is columnar, it means that the gland is hyper functioning. Blood supply, it is going to receive the blood supply from superior thyroid and inferior thyroid. Sometimes it is going to have a middle thyroid which is not going to be present. Middle thyroid vein is there. Sometimes an arterial branch might come, not routinely given, less than 0.1% incidence, and it might also have which is called as a thyroid ema artery, which is a direct branch from the arch of aorta. Venous drainage is definitely into three pair of veins, superior, middle and inferior veins, and these are going to drain into the brachiocephalic trunk. And lymph nodes, it is going to drain into the central group of lymph nodes, which is going to be also called as the Delphian lymph node. So Delphian lymph node is the pre-laryngeal lymph node and the pre-tracheal lymph node. So level 6 is consisting of two regions, pre-laryngeal and pre-tracheal. So pre-laryngeal is also called as Delphian lymph nodes, and then comes the pre-tracheal group of lymph nodes. And isthmus, remember, it lies along the second and third tracheal rings. So whenever you are doing an elective tracheostomy at the T2 and T3, the tracheal 2 and tracheal 3 region, that time you might have to cut the isthmus electively. So isthmus can be cut electively and then the tracheostomy can be done. And pyramidal lobe might be present in 50% of the people. So let's see the thyroid gland anatomy. What is the thyroid gland anatomy? So here you can see the pretracheal lymph nodes, very much important here. So this is the gland. Some people might have this pyramidal lobe. So here you can see some people might have this pyramidal lobe. I hope the pyramidal lobe is clearly seen here, the pyramidal lobe. Then there is going to be the superior thyroid artery. Superior thyroid artery is going to be there. This is the superior thyroid artery. Superior thyroid artery, and this is your inferior thyroid artery. So here either say inferior thyroid artery is going to supply the gland. Always remember that when you are dealing with the artery, whenever you are dealing with the artery, it is closely related with two nerves. Sir, which are the two nerves? So this is the nerve, this is the nerve 1, this is the nerve 2. I hope it is clear. These are the recurrent laryngeal nerves. So inferior thyroid artery के पास में रहेंगे recurrent laryngeal nerves, and superior thyroid artery के पास रहने वाले है तुम्हारा external laryngeal nerve. Sir, which is the most important nerve? अगर उड़ानी ही है nerve तो कौन सी उड़ाओ? तो external ही उड़ाओ. Never cut the recurrent laryngeal nerve, because recurrent laryngeal nerve will cause vocal cord palsy. So we are going to deal with the nerves furthermore when we are going to talk about it, but always remember that this is going to be the basic gland. It is a pyramidal shaped gland. It is going to be suspended on the second, third and the fourth tracheal ring at the isthmus. It is going to have blood supply from 2 arteries and venous drainage by 3 veins. The lymphatic drainage is going to be pretracheal and prelaryngeal group of lymph nodes, which are called as Delphian lymph nodes. Now coming down to the nerve, which is going to be very much important. So nerve is going to be very important. So left recurrent laryngeal nerve and right recurrent laryngeal nerve. So left लंबी है या right लंबी है? तो obviously left is going to be hooks around the ligamentum arteriosum and the aortic arch, and it runs in the tracheo-oesophageal groove. So अगर अब हम if we are going to talk about the recurrent laryngeal nerves, you can see that this is going to be the left vagus nerve. The left vagus nerve goes down, and while going at the aortic arch, it is going to give off the branch which is going to be your recurrent laryngeal nerve, and this recurrent laryngeal nerve is in close proximity to the gland and it lies in the tracheo-oesophageal groove. So you can see this recurrent laryngeal nerve which is lying in the close proximity to the tracheo-oesophageal groove. What is the clinical importance to it? Always remember that left recurrent laryngeal nerve being more longer, it is more long, and that is the reason the course is comparatively straight. But the right recurrent laryngeal nerve gets wind around the right subclavian artery which is higher, and that is the reason this nerve is going to be oblique in direction and not straight in direction, and that is the reason the right nerve is going to be a bit oblique and the left nerve is going to be more straight. And where is the landmark where you are going to find the nerve? We are going to soon see all the landmarks where the nerve we are going to find. So left recurrent laryngeal nerve, it runs in the tracheo-oesophageal groove. Right recurrent laryngeal nerve hooks around the right subclavian artery and enters the groove more laterally. So notes में भी मैंने importantly mention किया है, 2% of the right recurrent laryngeal nerves might be non-recurrent. तो ऊपर के ऊपर ही ब्रांच देके वो वेगस चली जाएगी. It will not cause any type of recurrence. It enters larynx directly from the vagus nerve and it is associated with aberrant right subclavian artery. So many times what happens is this right subclavian artery might originate aberrantly from maybe from the right carotid artery or even from the left carotid artery. So whenever the right subclavian is going to be aberrant, so that is the time the vagus nerve is going to drop off the nerve there and there when it is going to cross the gland and the larynx. The nerve passes posterior to the Berry's ligament and enters the larynx at the cricothyroid joint. All the words are very much important. The nerve passes posterior to the Berry's ligament. What is Berry's ligament? So Berry's ligament is nothing but it is a condensation of what? Condensation of pretracheal fascia. So Berry's ligament is a condensation of pretracheal fascia, and that condensation you can see very much rightly here that this condensation is going to aid in the gland attachment to the trachea. So this condensation of the pretracheal fascia उसके deeply या posteriorly जाने वाली है तुम्हारी recurrent laryngeal nerve. So very much important that when you are dissecting the gland of the trachea, when you are cutting the Berry's ligament, here the patient might land up into what is called as a vocal cord palsy because you are going to damage the nerve. So the nerve is most commonly damaged not at the inferior thyroid region but during the time of Berry's dissection. But now God has given you another challenge. What is that challenge? Here you can see that there is going to be the branch of inferior thyroid artery near the Berry's ligament. So many times while dissecting the Berry's ligament, many times when you are going to dissect the Berry's ligament, here you can have what is called as torrential bleeding. So bleeding control करते टाइम गलती से कॉटरी लग गई तो ये नर्व भी उसके साथ डैमेज होगी एंड देन द पेशेंट विल एंड अप इनटू वोकल कॉर्ड पैरालिसिस. सो डू अ वेरी फाइन डिसेक्शन व्हेन यू आर कटिंग ऑफ द Berry's ligament. That is important. So how you are going to spot the recurrent laryngeal nerve? Firstly, it is in the tracheo-oesophageal groove. So there is going to be a triangle. So what is the triangle? So always remember, it is going to be a Baer's triangle. What is Baer's triangle? Baer's triangle is anterior border itself is going to be the nerve. Anterior border itself is going to be the nerve. The posterior border is going to be the common carotid artery. So this is the common carotid artery. This is going to be the RLN, and the superior border is going to be bound by inferior thyroid artery. The inferior thyroid artery is going to be formed. It obviously gets from the brachiocephalic trunk or the subclavian artery. So whenever you are going to go for the nerve tracing, the first point where you are going to trace the nerve, it is going to be at the level of the Baer's triangle. So this is the Baer's triangle, and Baer's triangle ka content nahi hai. It is the anterior border of the Baer's triangle. So that is the first point where you are going to spot the nerve. अगर उधर नर्व नहीं मिली तो यू कैन while you are going to lift the lobe, there is going to be what is called as a tubercle of Zucker candle. So nerve is going to lie posterior to it. So here you can see that when you are lifting the gland, so इधर क्या रहेगा अपना, इधर तुम्हारा common carotid artery रहने वाला है. So this is the CCA, this is going to be the inferior thyroid artery, and this is going to be the nerve. This is nothing but this is going to be your Baer's triangle. Sir इधर नहीं मिला तो और ऊपर कहाँ मिलने वाला है मुझे, तो और ऊपर मुझे मिलने वाला है when I am going to actually go for mobilization of the gland. This is your tubercle of Zucker candle. So tubercle of Zucker candle के just posterior से ये nerve जाने वाली है. So ये सब चीजें मुझे जब मैं सर्जरी सीख रहा था तो पता चला. So what is important in recurrent laryngeal nerve? कैसे ट्रेस करना है? It is very much important. Left is going to be straight, right is going to be more lateral. Left is going to be there always, and right might not be present. Then when you are going to find out is going to be the Baer's triangle. So Baer's triangle gland के नीचे है, anterior boundary is going to be formed by the nerve. The second place where you are going to spot the nerve, it is going to be at the tubercle of Zucker candle. And if it is not going to be there still, if you are not able to spot it, then you can actually look it off when you are going to dissect the Baer's ligament. So उसके भी ऊपर हमें मिलने वाला है Baer's ligament. So while dissecting the Baer's ligament, you can actually find the nerve. So very much important when you are talking about thyroid surgery, how are you going to spot the nerve is going to be the examiner's question. जैसे parotid में हमने देखा कि how are we spotting the facial nerve, here the very much important pointer is going to be how are you going to spot the recurrent laryngeal nerve. Quick revision, how are you going to spot the recurrent laryngeal nerve? The first thing is the Baer's triangle. Here you can rightly see that the Baer's triangle is forming the anterior border of the Baer's triangle. It is not the content. The Baer's triangle, the anterior border is formed by the recurrent laryngeal nerve. Second, if you are not finding, you can go for tubercle of Zucker candle. Here the tubercle of Zucker candle is there, and the nerve is going to exit posterior to the tubercle of Zucker candle. And third, while you are going to dissect the Baer's ligament, you are going to encounter the nerve. And we have already seen that while dissecting in this area, there are branches of inferior thyroid artery, and here it is going to bleed torrentially. So always remember to take good control of the bleed, and then you are going to go for the nerve dissection, or while doing the cautery you might damage the nerve. So we have talked about the recurrent laryngeal nerve in the very beautiful manner. As much as surgically the things are important, so that is important. So if it is going to be a unilateral nerve palsy, anytime if a unilateral nerve palsy is going to be present, slowly by slowly the contralateral nerve is going to take off. The contralateral nerve is going to take up the function, and then the patient is going to have the contralateral cord hypertrophy. So important for you to know that which type of nerve palsy is there and how are you going to manage the patient when it is going to present to you. What is the external branch of superior laryngeal nerve? It is not that important when it as compared to recurrent laryngeal nerve, because even if you are going to cut it, it doesn't mean that you are going to cut it. But even if the time comes that you are going to damage it, only the high-pitched voice is going to have some problem. It runs with the superior thyroid artery and risk during the posterior pole ligation. Injury is going to cause a high-pitched voice. So cricothyroid paralysis, we know that cricothyroid is the extensor and it is the singer's nerve. So your bathroom singing is going to eventually land up into trouble. Rest, all the voice and everything is going to be normal. And Serena classification defines its relation to the superior thyroid artery. So there is a classification called as Serena classification. You don't need to be by-hearting the classification, not at the level of your UG or even at the level of first or second year PG. But something is important for you to know that Serena classification type 1, type 2, type 3, it is based on how the gland is going to be, how the nerve is going to be in relation with the artery, how close is the nerve relation to the artery. And always remember, type 2 is going to be dreadful, type 2 is going to be dreadful. Just take home point, even if it is not remembering, it is fine, but these names you should be knowing. So any patient who is going to come to you with thyroid problem, so in surgery OPD, the patient is going to come predominantly with a thyroid swelling. In medicine OPD, the patient is going to come with symptoms. So any patient with thyroid swelling is going to come to you. What are the differential diagnoses? So any thyroid swelling, what you can think of first is going to be goiter. Goiter means thyroid swelling, but what are the types of goiter you are going to discuss? So what are the types of goiter? So one might be a diffuse goiter. The second might be MNG. It is a multinodular goiter. Another might be a single or solitary nodule. Third might be, yes, it might be a malignancy. So ये चार चीजें हमें रूल आउट करनी है. Simple. Whenever the patient is going to have a thyroid swelling, all the four things should be in your mind, that it might be a diffuse goiter, might be a physiological goiter, or might be sometimes because of iodine deficiency. अगर वो पेशेंट प्रोग्रेस करेगा तो इट माइट लैंड अप इनटू मल्टीनोड्यूलर गॉइटर. मल्टीनोड्यूलर गॉइटर है तो इट इज नॉट गोइंग टू रिग्रेस. सो पेशेंट को कॉस्मेटिक प्रॉब्लम है तो एमएनजी शुड बी रिमूव्ड. क्या करने का सब हम धीरे धीरे देखने वाले हैं, बट व्हेन द पेशेंट इज गोइंग टू हैव एमएनजी यू शुड बी रिमूव्ड. सॉलिटरी नोड्यूल अगर है तो उसको कैसे इवैल्यूएट करने का, तो वो भी हम लोग देखने वाले हैं. एंड अगर मैलिग्नेंसी के फीचर्स लग रहे हैं, सो व्हाट आर द फीचर्स ऑफ मैलिग्नेंसी. जैसे पैरोटिड ग्लैंड में हमने देखा कि द features of malignancy are going to be the facial nerve involvement, the encasement of the fascia, ulceration. तो वैसे ही थायराइड में क्या रहेगा, थायराइड में predominantly malignancy के फीचर्स रहेंगे. recurrent nerve paralysis, patient might have hoarseness of voice, patient might have fixity to the gland, patient might have transient ischemic attack because of encasement of the carotid. There might be lymph nodes around the level 6 or even lateral nodes if the malignancy is advancing. So ये चार ही चीजें पेशेंट के साथ आने वाली है. So these four things are the related to the swellings. Each swelling में क्या करने का, कैसे इन्वेस्टिगेट करने का, वो सेपरेटली हम लोग देखने वाले. But here what is important for you to know that generic any swelling of the thyroid if comes to your OPD, first thing is thyroid function test. तो पेशेंट आते आते ही उसको बोलने का कि गिव योर ब्लड फॉर थायराइड फंक्शन टेस्ट एंड देन वील गो फॉर फर्दर इन्वेस्टिगेशन. सो फर्स्ट लाइन इन्वेस्टिगेशन, टीएसएच इज मोस्ट सेंसिटिव. सो टीएसएच कम है या ज्यादा है उसके ऊपर हमारा अगला मैनेजमेंट है. सो इफ टीएसएच इज लेस, it means that the gland is hyper functioning, so your investigation is going to change. If TSH is more, it means that gland is hypo functioning, hypothyroidism है patient को, so then you are going to change the line of your further investigations. What are the other investigations you are going to do? A thyroid USG. So USG में क्या पता चलेगा? So any swelling in the USG, they are going to tell you about the size of the nodule, and after knowing the size of the nodule, you are going to tell about the high risk features. So it is very much important. So it is the workhorse imaging. Bailey states that it is the workhorse imaging. So it is a freehand method, gives better yield access to vascularity, echogenicity and nodes. How to go for the approach to thyroid swelling we are going to just talk in a while. FNAC is important. अगर USG में लगा कि ये हाई रिस्क है, FNAC कर लो. FNAC में you are going to check whether it is a benign or malignant. In parotid lesions, we saw that FNAC is going to only tell about inflammation. There is no going to be any role of malignancy in FNAC. But here in thyroid, you are going to check if the swelling is going to be malignant or not based on FNAC. CT scan for typically neck nodes and vascular involvement and airway assessment. Also, if the retrosternal extension is there, you can check for that. MRI is very important for prevertebral fascia involvement because involvement of prevertebral fascia makes the tumor non-resectable. Better for posterior extent for malignancy. PET scan करोगे. PET scan usually is not indicated for all differentiated cancers. So, which investigation is important? For differentiated cancers. So when we are talking about malignancy, malignancy can be divided into differentiated and non-differentiated, differentiated and non-differentiated. So differentiated के लिए रेडियो आयोडीन स्कैन करना पड़ता है, रेडियो आयोडीन स्कैन करना पड़ता है. So whole body radio iodine scan, it is important for differentiated swellings. When it is a non-differentiated swellings, PET scan का रोल उधर आ जाता है. And antibodies might be important when you are dealing with the diseases like autoimmune thyroid diseases like Hashimoto's thyroiditis, Graves disease. तो उसमें thyroid के antibodies हमें आने वाले हैं. So thyroid peroxidase antibodies or which are seen typically in the Hashimoto's disease, and in Graves disease हमें मिलने वाले thyroid stimulating antibodies, TSH stimulating antibodies. Thyroid receptor antibodies are seen in Graves disease. So it has more prolonged action, 24 hours versus TSH के 2 to 3 hours के antibodies. So even after treating the Graves disease, the antibodies are going to be there, and that is the reason their half life is going to be 24 hours in the blood. So it is going to be normal TSH का half life कितना रहता है, 2 to 3 hours. But when you are talking about TSH receptor antibodies, the half life is going to be 24 hours. So it is very much important. So now we are going to talk about how are you going to approach a patient with a thyroid swelling. So any patient who is come to you with the thyroid swelling. So thyroid swelling या फिर goiter का patient हमारे पास आने वाला है, तो what are you going to do? Here you are going to first rule out the clinical signs of emergency. So clinical signs of emergency. So what is emergency? It might be airway compromise, or it might be yes, thyrotoxicosis, or it might be myxedema coma. So if these things are present, you need to manage the patient intensively and stabilize. So So you should intensively stabilize the patient. After you are going to go for stabilization, then you are going to do what is called as the TSH. So TSH karo and T3 T4 karo. But T3 T4 are supplementary. The workhorse is going to be TSH. So TSH करो. TSH करने के बाद में हमें पता चलेगा कि is it going to be a hypo or euthyroid, or it is going to be a hyperthyroid. So if it is going to be a euthyroid state, it means that factory बंद है तो कुछ अंदर गड़बड़ चालू है. We know that whenever you are going to come across some factories which are going to be closed for long decades, it means that there might be some problem there. There might be some drug smuggling going on, some cash exchange going on, some fake currency generation. हमने सब मूवीज में अब तक देखा है. So hypo functioning gland मतलब कुछ ना कुछ गड़बड़ है. तो इधर हमें करना है पेशेंट का USG प्लस माइनस FNAC. Plus minus FNAC. If it is a hyperthyroid gland, you are going to go for radioiodine uptake scan. Radioiodine uptake scan. Radioiodine uptake scan. Radioiodine uptake scan. So which investigation to be done in which patient is very much important. For that you need to go for what is called as a TFT. TFT में अगर hyperthyroid आया तो क्या करना है, तो radioiodine uptake scan करना है. And अगर TFT में hypo और euthyroid आया तो you have to go for a USG और FNAC. किसके लिए? अगर thyroid swelling है तो. अगर swelling ही नहीं है तो वो medical management आता है बच्चों, तो उसमें medical management में जाना है. But if it is going to be a euthyroid or hypothyroid with a swelling, with a goiter, then this is the line of management. And then you are going to go for a separate management, which I am going to tell you. So this is the basic protocol. Whenever any patient of thyroid swelling comes to you, I am minding you, I am telling a thyroid swelling, not a functional thyroid problem. A thyroid swelling or a goiter when the patient is going to come to you. First clinical signs of emergency rule out karo. Send the patient for stabilization. After stabilization, the first investigation you are going to do is going to be a TSH. You are going to go for TSH. TSH में अगर U या फिर hypothyroid है तो you are going to go for USG and FNAC. USG plus minus FNAC. And if hyperthyroid है तो you are going to go for radioiodine uptake scan. So radioiodine uptake scan you are going to go for if the patient is hyperthyroid. I hope it is crystal clear. सर FNAC कहाँ करूँ, FNAC कहाँ करूँ? तो USG में बच्चों वो बताने वाला है that USG the radiologist is going to tell you about the first size. So any lesion less than 1 centimeter, any lesion less than 1 centimeter, you have to straight and straight go for, yes, you have to go for surveillance. 3 monthly or 6 monthly, whatever your institution is going to follow. Sir, if the lesion is more than 1 centimeter, then what are the things you are going to check in that? So they are going to give you what is called as Thyroid. So thyroid imaging and reporting and data system. So they are going to give you Thyroid. So what are the things they are going to look for? They are going to look for heterogeneity. Then they are going to look for taller than wider nodules. Taller than wider nodules. Sir, तीसरा कौन सा चीज इंपॉर्टेंट है? So it is going to be vascularity. चौथा कौन सा है? कैल्सिफिकेशंस. तो ये अगर सब चीजें अगर तुम्हें यूएसजी में दिख जाए, सो दीज इफ थिंग्स आर गोइंग टू बी देयर इन द यूएसजी, दीज आर गोइंग टू, उसको सबको पॉइंट्स दिए हुए हैं. तो थायराइड स्कोर अगर हम लोग बाय हार्ट करने लगेंगे तो देन इट माइट टेक टाइम फॉर अस टू कवर अप द थायराइड एंड ऑल्सो देन वी माइट गो इनटू रेडियोलॉजी सेक्शन. बट बेसिकली ऑल दीज थिंग्स, हेटेरोजेनेसिटी, टॉलर देन वाइडर नोड्यूल, हाइपरवैस्कुलर, कैल्सिफिकेशंस प्रेजेंट, इफ ऑल दीज थिंग्स आर देयर इन द थायराइड ग्लैंड इन द यूएसजी and the lesion is more than 1 centimeter, then they found out that here you have to go for what is called as FNAC. You have to go for FNAC. सर लेस देन 1 सेंटीमीटर में अगर ये लीजन्स है तो क्या प्रॉब्लम है? दे हैव फाउंड आउट दैट इफ लेस देन 1 सेंटीमीटर एंड यू आर गोइंग टू गो फॉर FNAC, इवन इफ द यील्ड दे माइट टेल यू लेस देन 1 सेंटीमीटर एनी ट्यूमर विच इज डिफरेंशिएटेड, दे आर गोइंग टू टेल यू एज माइक्रोपैपिलरी कैंसर. And if there is going to be a micropapillary cancer, if it is going to be a micropapillary cancer, you don't need to do any treatment because the prognosis of the patient is going to be same. So the prognosis of the patient is going to be same. So even if no treatment, micropapillary cancer needs to go for surveillance. So no anything doing if the lesion is less than 1 centimeter. So that is the rule of the art. So important for you to know. And if the swelling is less than 1 centimeter, no need to go for anything. So we talked about investigations. Patient आने के बाद हम लोग क्या क्या करने वाले हैं? So USG malignant features में क्या क्या है? Microcalcifications, taller than widal nodules, heterogeneous ecostructure, irregular margins and vascularity. So the fifth thing which I missed out is going to be the irregular margins. So ये 5 basis पे उन लोगों ने they have designed the thyroid score. So thyroids agar 3, 4, 5 hai, so it means that it might be more malignant, so you have to go for what is called as FNAC. If it is not that much, then you can wait and watch. You don't need to go for an FNAC. And then comes the FNAC का report. So FNAC मैंने भेज दिया because thyroids were high. I was suspecting malignancy. So what am I going to do? Then one is going to be non-diagnostic. It means that the FNAC is non-conclusive. Repeat FNAC करना पड़ेगा. 2 is benign. 3 is going to be a typical or a significant follicular lesion of unknown significance. 4th is going to be follicular neoplasm, and 5th is going to be suspicious, and 6th is going to be malignant. So Bethesda ने क्या किया? Bethesda ने क्लासिफाई करते वक्त 6 सिस्टम में क्लासिफाई किया. So what are those 6 systems? 1 is non-diagnostic, 2 is benign, 3 is atypical or it is going to be follicular lesion of unknown significance. So you don't know if it is malignant or not. 4th is going to be a follicular neoplasm. 5th is suspicious malignancy. 5 is malignant. So clear है इसके आगे क्या करना है. When we are going to talk about the thyroid malignancy, we are going to discuss about the Thai classification and the thyroid Bethesda classification. So there is another classification which is called as a Thai system, so THY. So another system is going to be the Thai classification, THY. So वो system में क्या करना है, तो उसमें score रहता है Thai 1 to Thai 5. So what is the difference between them? So the difference is that they have not included this category. So this category is not included in the Thai system. So how you are going to manage the patient of thyroid neoplasm? We are going to talk about when we are going to talk about the malignancy. So what are the types of thyroid swelling? So here you can see that this is the large amount of goiter. This was a papillary C of thyroid which we operated. So what you are important, if it is euthyroid inflammatory swelling, euthyroid and inflammatory swelling, it is going to be no abnormality and it might be an inflammatory cause. Physiological goiter can be seen in puberty, pregnancy, and it is usually reversible. So always remember, any diffuse goiter, it is going to be reversible. So उसके अंडरलाइन कॉज को तुम लोग करेक्ट करो. अगर ग्रेव्स डिसीज है विथ डिफ्यूज गोइटर विथ ग्रेव्स डिसीज करेक्टेबल. बट अगर उसमें नोड्यूल्स फॉर्म होने लगे, इफ इट प्रोग्रेसेस टू मल्टीनोड्यूलर गोइटर और इफ इट डेवलप्स नोड्यूल्स, देन देयर इज नो कमिंग बैक. सो दैट इज द टाइम व्हेन यू आर गोइंग टू रिक्वायर अ सर्जरी. सर मल्टीनोड्यूलर गोइटर अगर पूछेगा, मल्टीनोड्यूलर गोइटर इट इज अ लेट स्टेज ऑफ डिफ्यूज गोइटर. सो इट माइट हैव follicular hyperplasia and nodule formation. Sir, one take home point, these nodules which are there, these nodules are non-functional. So the nodules are going to be non-functional. These are going to be non-functional. टॉक्सिक नोड्यूलर, सो उसमें अगर नोड्यूल्स कुछ अपने आप काम करने लगे, कुछ हाइपर फंक्शनिंग होने लगे, सो इट इज गोइंग टू बी अ टॉक्सिक नोड्यूलर गोइटर. So it might be a toxic MNG or sometimes a diffuse Graves. So hyperthyroid state or might be in Graves disease, or these nodules are autonomous. Neoplastic, it might be a follicular adenoma or a carcinoma. Autoimmune, Hashimoto's thyroiditis, it is because of hypothyroid state. Autoimmune can be hypothyroid or it can be hyperthyroid when it is Graves disease. Whenever there is going to be a rapid fibrosis and hardening of the disease, it might be a malignancy or it might be which is called as a Riddle's thyroiditis. It is going to be causing dense fibrosis of the gland and it is also associated with retroperitoneal fibrosis. कौन सा disorder है जो retroperitoneal fibrosis भी cause करता है and it might cause Riddle's thyroiditis? It is IgG4 disease. It is IgG4 disease wherein there is going to be fibrosis of everywhere in the body. So Riddle's thyroiditis with retroperitoneal fibrosis typically seen with IgG4 disease. De Quervain's thyroiditis or what is called as granulomatous thyroiditis, after a viral infection, the gland is going to become tender, there is going to be inflammatory lesions. So basically gland is going to have an inflammatory state of goiter and it is also going to subside. So you can treat it with the steroids. So whenever the patient is going to have any upper airway disorder, we have seen Epstein-Barr virus, we have seen the infectious mononucleosis like features. So most of the times after the sequelae, there is going to be some transient autoimmune destruction of the gland because of those antibodies formed against the virus. So it is a post-viral, it might have raised DSR, the gland might be tender, treated with steroids for 6 to 8 weeks and it is going to subside. Very much important. And infective causes are rare, like abscess, thyroid abscess is going to be rare. Acute suppurative thyroiditis, it might be bacterial or post-trauma or due to immunosuppression. Very much important. So just before going, we are going to see how the nodule is going to form. In the diffuse state, the goiter is reversible with iodine and thyroxine supplementation. So whenever, even in Graves disease, you are going to treat the autoimmune antibody condition, it is going to be reversible. Once the nodule forms, due to necrotic and regrowth pattern, the nodules are non-functional. So the nodules are non-functional, the gland between the nodules is actually functional. Colloid goiter, so it is going to be the next stage wherein the TSH starts falling and many follicles are filled with the colloid. So it is the burnt out stage. So whenever the patient is going to have iodine deficiency, initially there is going to be a diffuse goiter. Then the patient will have multinodular goiter. Then what happens? The gland will go into exhaustion. There is going to be no hormone, but only colloid is going to form. And once nodules are developed, the entire gland becomes microscopically abnormal. So there is no use of keeping the gland. So nodules develop early in endemic region and late in the sporadic goiter. So there are few regions which are endemic for goiter. So udhar tendency of forming goiter is more. But if there is a sporadic goiter, so the nodules development becomes later on. So many times if you go in the belt of northeastern Himalayas, nowadays because of iodized salt, because of those national health programs, because of iodized salts, basically iodine deficiency has reduced a lot. But even if you are going to see those endemic region, people are going to be more prone for development of nodules than the people who are not staying in those regions. And it is more commonly in female because there is some estrogen receptor co-stimulation. We already saw that in ductal glands of the salivary gland neoplasm, there is going to be again estrogenic and androgenic response. Here also we are seeing the same thing. So very much important for you to know. So what is important for you to know that nodule once is formed, it is going to be irreversible. If the patient is demanding for removal of the gland, then thyroidectomy is the only option. The nodules cannot go, but the diffuse gland is always reversible. And what are the goiterogens? So goiterogens are nothing but who are going to precipitate the goiter. It is low iodine and high calcium diet. So not just low iodine, but high calcium diet is very much important. So these are the endemic. So this is the problem in the endemic goiter regions. Thiocyanate. So what are the thiocyanate? They are typically found in the cassava, brassica and vegetables and in the cabbage. So what happens is they are going to interfere with the iodine trapping. So thiocyanates are going to interfere with the thyroid trapping, the iodide trapping. Tomorrow we'll see the physiology of the gland first before going ahead, and then we are going to see where these hormones are going to block. Carbimazole and propylthiouracil, it interferes with the organification. So we know that the iodine is oxidized. So taken iodine is oxidized inside the gland and then attached to the thyroglobulin molecule. So tomorrow while we are going to see the physiology in short with the diagram, that time we will see that this carbimazole is going to interfere there, and lithium also inhibits the thyroid hormone release. So any patient on lithium, you have to go for TFTs before you are going to go for operation, because these patients might have a deranged thyroid hormones. So I hope it is clear. We have started basics of the thyroid gland. We have seen how to approach a patient of any thyroid swelling typically seen in the OPD. What are the investigations done? When we are going to go for FNAC, when we are not going to go for FNAC, when we are going to just conserve the patient, what is micropapillary malignancy, we have seen in the today's lecture. So if any doubts are there, you can ping me on WhatsApp or post it on Instagram. I will be more than happy to help you. So I hope it is clear. We will meet tomorrow again, and then we are going to continue with the remaining thyroid module. I will share the PDF to you tomorrow itself before starting off with the lecture. I hope it is clear. So thanks for attending lecture. Till then, take care. Bye bye and good night.